Welcome to Pharmacology Insights, where we break down complex pharmacology into simple, easy to understand concepts. 2 patients. Same diagnosis. Same drug. Same dose. One feels nothing. The drug does nothing. The other one? He ends up in the ICU fighting for life. This isn't bad luck. It isn't a medical error. This is your DNA quietly dictating how your body handles a drug. Welcome to Pharmacogenomics, the science of how your genes shape a drug's fate. We're going to talk about enzymes, gene variants, and how a single genetic change can turn a standard dose into either a cure or a catastrophe. Let's get into it. When you swallow a pill, your body doesn't just passively absorb it. The body processes it. It absorbs, distributes, metabolizes, and excretes the drug. We call this ADME. Absorption, distribution, metabolism, and excretion. Of these, metabolism is where genetics plays its most decisive role. Think of your liver as a chemical processing plant. It uses specialized tools, known as enzymes, to break down drugs so your body can use them or get rid of them. Because here's the thing. Not all livers work the same way. 2 people can have slightly different versions of the enzyme, coded by slightly different genes. And that small difference can completely change what happens to a drug. One person clears it too fast. Another clears it too slow. The result? No effect. Or toxic levels. At the center of this system is a family of enzymes known as cytochrome P450, or CYP450. CYP450 enzymes are a superfamily of heme-containing proteins found primarily in your liver, also in the gut and other tissues. Their job is straightforward. They convert fat-soluble drugs into more water-soluble forms, so they can be excreted. There are over 50 CYP450 enzymes in humans. But in clinical pharmacology, a small group does most of the work. CYP3A4, CYP2D6, CYP2C9, CYP2C19, and CYP1A2. These 5 enzymes together handle the majority of commonly prescribed medications. Now, here's where it gets personal. The genes that encode these enzymes are polymorphic. They vary between individuals. These variations, whether single nucleotide changes or larger structural differences, can dramatically change how active the resulting enzyme is. One change in the DNA sequence, and an enzyme might work at 20% capacity. Or not at all. Because of genetic differences, or polymorphisms, we don't all metabolize drugs the same way. Most people fall into 4 categories. First, normal metabolizers. Enzyme activity is as expected. Standard doses work predictably. Next, intermediate metabolizers. In these individuals, their enzyme activity is lower than normal, so drugs may accumulate. Side effects become more likely. The third category is poor metabolizers. This is where things get dangerous. Poor metabolizers have little to no functional enzyme. They can't break down the drug effectively. A standard dose can behave like an overdose. Not because of a prescribing error, but because the body simply cannot process the drug. And on the opposite extreme, the ultra-rapid metabolizers. These individuals have highly active enzymes or extra gene copies. They clear the drug so quickly that therapeutic levels are never reached. The drug fails. Not because it doesn't work, but because it never had the chance to. Now, let's see what this looks like in real patients. Codeine is an opioid analgesic used to treat moderate to severe pain. It is a prodrug. On its own, it's relatively inactive. It must be converted into morphine by CYP2D6 to produce analgesia. In a normal metabolizer, this works perfectly. But in an ultra-rapid metabolizer, the story changes. Codeine is converted into morphine rapidly, and in excess. Morphine floods the system. Respiratory depression can follow. And in severe cases, death. This is not theoretical. There are documented cases, including the death of a breastfed infant who died because the mother, an ultra-rapid metabolizer, was prescribed codeine. The morphine actually accumulated in her breast milk. No one knew her genotype. Until it was too late. As a result of cases like this, regulators, including the FDA and the EMA, have since issued strong warnings and restrictions on codeine use in high-risk groups. Now consider the opposite case. A poor metabolizer taking codeine for pain. They can't convert it to morphine. They get no analgesia. The drug simply doesn't work. Escalating the dose doesn't fix the problem. It only increases the risk of side effects. Same drug, same dose. But completely different outcomes. Clopidogrel is one of the most commonly prescribed antiplatelet drugs in the world. It's given to patients after heart attacks, coronary stents, and strokes. Situations where you absolutely need this drug to work, because the alternative is another clot, another event, and possibly death. Like codeine, clopidogrel is a prodrug. It must be activated by CYP2C19 in the liver to become its active metabolite that inhibits platelet aggregation. A significant proportion of patients, especially in Asian populations, carry loss-of-function variants in CYP2C19. Say a patient in this cohort is prescribed clopidogrel after a coronary stent. The drug is never fully activated. Platelets remain active. So the patient goes on to have stent thrombosis, a clot in the stent, which can cause a massive heart attack. A potentially fatal event. This isn't a theoretical risk. It is a well-documented clinical reality. The FDA added a boxed warning to clopidogrel in 2010, highlighting reduced effectiveness in poor metabolizers. As a result, alternatives like ticagrelor or prasugrel, which don't require CYP2C19 activation, are now preferred in high-risk patients. In some settings, pharmacogenomic testing is used to guide that decision. Because knowing a patient's CYP2C19 status can be literally life-saving. The CYP450 polymorphism story plays out across pharmacology. Warfarin dosing is notoriously difficult. Part of the reason is that CYP2C9 variants affect how fast it's metabolized, and VKORC1 variants affect sensitivity to the drug itself. Get it wrong, and the consequence is bleeding. Another example is tamoxifen, used in breast cancer treatment. For the drug to work, it needs to be converted to its active form, endoxifen, by CYP2D6. Poor metabolizers have significantly lower endoxifen levels. And some studies suggest they have worse outcomes from tamoxifen therapy. This has real implications, for which breast cancer patients should receive tamoxifen versus aromatase inhibitors. Across all these cases, the principle is the same. The drug is only as effective and as safe as the patient's ability to process it. So is pharmacogenomic testing routine? Not yet, but it's moving in that direction. Several hospitals and health systems have implemented preemptive pharmacogenomic testing panels. You sequence the patient once, store the results in their electronic health record, and every time a relevant drug is prescribed, the system flags a potential interaction. The CPIC, the Clinical Pharmacogenomics Implementation Consortium, publishes freely available, evidence-based guidelines for gene-drug pairs. And the FDA now includes pharmacogenomic information in the labels of over 250 drugs. Sometimes as required testing, sometimes as recommendations, and sometimes just as information. Targeted testing, especially in psychiatry and cardiology, is becoming increasingly common. But barriers remain: cost, access, and clinician familiarity. There are also equity gaps. Most genetic data comes from European populations, limiting accuracy in other groups. Still, the trajectory is clear. Precision medicine isn't theoretical anymore. And pharmacogenomics is one of its most practical tools. Let's bring it all together. 1. CYP450 enzymes metabolize most drugs, and genetic variation creates major differences between individuals. 2. Metabolizer status has real clinical consequences. Poor metabolizers risk toxicity. Ultra-rapid metabolizers risk treatment failure. 3. Prodrugs like codeine and clopidogrel carry extra risk in variant metabolizers, because the activation step itself is compromised or exaggerated. 4. Pharmacogenomic testing is clinically actionable and in some cases, life-saving. And 5. When a drug behaves unexpectedly, too strongly, or not at all, think pharmacogenomics. It might not always be the answer, but it should always be on your differential. For decades, medicine has treated patients as averages. Pharmacogenomics challenges that idea. Because you are not an average patient. Your genome is unique. Your metabolism is unique. And increasingly, your treatment should be too. And that's it for today's pharmacology video. If you enjoyed this video, please give it a thumbs up and subscribe to the channel for more pharmacology content.